it's not doing the stuff they associate modern medicine with, right? It's not prescribing a lot of medications. It does prescribe medication, but really straightforward ones. Even you can figure it out. Like somebody's in pain, they give pain medication. Somebody is throwing up, they give something to counteract the nausea. I mean, that's all they do. And of course, in your mind, how is that going to make this person live longer? It doesn't, right? So it's a very strange field. And they start asking the person what they really want. And before they ask that, of course, I mean, you can't ask someone what they really want if they don't know what's happening to them. So they start asking them what the other doctors have already told them. And then if it's not yet clear to them, then they start talking to the other doctors, ask them and discuss with them the possibility of disclosing more information to the patient. It seems like they cannot move if nobody tells the family and the patient the truth, or enough truth for them to do their job. So they got associated with assessing disclosure, or assisting the other doctors with disclosure. Ideally, of course, they don't do the disclosure because they're just coming in and they're not the experts. And when you disclose an information to a family or a family member or a patient, and the information says something like, we've done everything that we can, but there's not a lot of things that we can do, extend your life or cure you. The next few questions will be why, how come, what happened, and definitely the hospice and palliative care person is not the right person to answer those things because he wasn't the one doing all the attempts to cure and prolong the life. Nobody wants to do disclosure. I mean, it's such an emotional thing. And if there's some people who are so interested in disclosure, maybe you just give it to them, right? And so a lot of disclosure, especially during the time when hospice and palliative care is just beginning, got punted to them. And of course, they're just starting, and then they want people to get them in on the case, so they kind of accepted things. But then, in some countries, they got it right. The idea is to remind or advise the other services that, you should be the one doing this, and if it's difficult for you, we can help you out. That's the idea. In some countries with very limited resources, or where the specialist feels like he's too busy, or this is not the kind of thing they've been exposed to. Even their teachers didn't do these kinds of things. They kind of punted things to them, and it made things more complicated. Now the guy disclosing would have to figure things out and learn from the specialist the information he should be disclosing, and then he'll disclose it himself. So the other suggestion, of course, would be just both of you sit down there, you answer the technical, scientific, what happened in the past part, why did this happen, why is this happening right now, and the other guy, the counselor or the psychosocial person or the hospice guy, whoever it is beside you, will take care of the stuff you're afraid of, the emotional part and all the crying and the stress and the trauma that's going to be experienced by the person you're talking to, because it's clearly bad news. So that's the topic of disclosure. You kind of watch these people, and the other thing you notice is they're also the kind of people who do home visit. They plan things out, and then the patient goes home. They do the home visit, especially if the patient cannot go back. They're so weak, and there's not a lot of things you can offer in the hospital, and they visit them at home, and they do whatever they do. You'd imagine they probably do something similar to what you've been doing in the hospital, except that they're doing it at home, and of course it's more conservative because the patient cannot afford all the resources of the hospital. So they got associated with home care, dying at home, and more conservative care. And conservative care means not using a lot of the modern day science, technology, and gadgets and things like that, which you can only get if you go to the hospital. Of course, modern day hospices, the ones in very affluent or resourced countries or communities, are capable of much more. But even them, they cannot approximate what the hospital can do. The home care stay, even with all the gadgets that you can pay for, so that home care can bring the hospital into your house, cannot approximate everything that you can have if you're inside the hospital. Right? So they're the home care people doing that, taking care of people who are dying. And it's even strange in some countries where there's no home care and hospice started ahead of home care. People thought hospice are home care people. Of course, the truth is home care can be anything. Like a rehab service can have a home care arm. A geriatric service can have a home care arm. An orthopedic service, post-op patients can have a home care arm. Or it's not really hospice, and those are not dying people. They're not the kind of thing hospice people study about or learn about or get exposed to. But there's a few countries who ended up doing that. Of course, it's not true. If you're in an institution like that, that can get you confused. Like, why are we taking care of people who are going to the home? And it doesn't seem like the kind of palliative and hospice care patients that we read about in our textbooks and our journals, and that's the reason why. Of course, the solution to that is you tell everyone that, they need to develop the other kinds of home care, which is not hospice and palliative care. I mean, that's, you have to remind everyone that those are different things, and obviously they lack some of them. Of course, the problem with home care is it doesn't earn much, and it's not paid for by insurance in some places, and it's expensive to put out. So you don't earn much from it, so they're underdeveloped. One problem with modern medicine is the things that earn much gets developed faster, and the things that don't seem to earn much don't get developed faster, because nobody would pour resources into something that won't earn much. I mean, if this is a commercial enterprise. So that's what it is. And this is fairly, in the 20th century, it was starting, but right now it's even more prevalent. The idea that medicine is partly a commercial undertaking. So there's this medical industry, which is true. There is such a thing as the medical industry, and it became so big that it actually rivals energy, one of the top industries in the entire planet. It's a business, right? If you look at it that way, and you will see why that kind of view kind of makes sense, right? You have all these big hospitals and big centers with all these employees and doctors and all this gadgetry, and those things cost money. They don't come free, right? So, and you can actually just look at all these things and you can ask yourself, where's all the money coming from? I mean, how do you keep these things going? Where's the money coming from? This is not like charity. It's like a huge enterprise, right? And you look at the drug industry. You do research, and researchers cost millions of dollars. That's one research, and then you need to do a series of them. And then there's this journals, publication, the circulation, getting the conferences, and you look at the conferences. I mean, they're not cheap places. I mean, they're like 5-star hotels and expensive food, right? And people even go to places, airfare and all. I mean, this is such an expensive enterprise, right? Where's all the money coming from? Things involve money. I mean, you cannot prop that up with no money, right? So it's a business, right? You put something in, you get something back. Not unless all the money is coming from the government. In the early part of the 20th century, money is coming from the government and from private medical industries. In this century, even the governments of developed countries don't have that much resources anymore. I mean, there's a series of financial crises, and even the developed countries are getting into debt. And they notice one of the biggest things they spend for would be healthcare. So they cut down on spending for healthcare, research, and things like that. So where's all the money coming from? Well, it's coming from the other one, the private medical industry. That part is a business enterprise. You don't become a multi-billion-dollar healthcare corporation. It could be a managed care corporation, a healthcare delivery corporation, a big hospital with lots of satellite hospitals and satellite clinics and lots of employees, a multi-billion-dollar medical equipment industry or a pharmaceutical industry. If you don't earn anything, you put in money and you earn more money and you grow bigger. That's how the medical and healthcare industry became so big, rivaling even the energy industry, oil and stuff. I mean, that's big, that's huge, right? So there's a lot of money involved. And so, going back to hospice and palliative care, if we define things that way, and doctors are part of that system, so you go into the medicine, but you expect to earn something because it's, you're like middle level managers in a big corporation, not the lower level of people. So lower level people will be the professions under you. So you want to think, and you want to think of yourself as somewhere near the top. Of course, that's not completely true for many. So the question is, why are you going to do all these things? There's no money going into it. I mean, this is a very strange proposition, right? Insurance companies don't really pay much for hospice and palliative care. In some countries, they don't even pay for it, period. If you get into the hospital, they pay for it. You go at home and then you say, you won't go back in the hospital, you pay for it yourself. And how can you support such an enterprise if nobody's going to pay for it? How can you bring ventilators and all sorts of stuff to the house if you cannot pay for it? What doctor will go in there and do this very physically demanding and emotionally demanding job, knowing that they're not going to get paid as much, or they're not going to get paid at all, or they have to make do with whatever resources the patient had? By this time, since this is an advanced disease and the specialists have tried their best to apply all the stuff that they know in the hospital to make it go away and didn't go away, probably this patient is about to run out or is running out of resources to pay you. So it's a very strange thing. I mean, who are these people? I mean, why would you do such a thing? It's like you're either a saint or you're doing something else and you're making money out of it. Everybody dies in the end, so you can have a lot of patients and earn money from it as long as you can figure out how to make money out of it. In some places in the world, and in some countries or in some areas, especially in metropolitan areas in countries, if there's something malevolent or malicious or corrupt that's going to happen, it's going to happen there. People can come up with ways to make money out of certain things. So of course, usually you cut corners and you promise something, you don't deliver, and that's pretty much how you make money, right? Of course, if we don't talk about those things, and the question is, how can you deliver holistic care and taking care of you at home instead of you going back to the hospital if you don't have the resources to get it to work? So that's a big problem. So when people look at this hospice and palliative care thing, there's a lot of confusing things about it. This kind of care, this kind of population is not going to give you as much earnings or income, as much financial return if you're a doctor or a hospital or a corporation or a company or a healthcare corporation or a pharmaceutical or medical gadget company. And it's not going to give you as much return as people who are not dying. Even the people who are sick, some people are not even willing to pay for a hospice. What's the point of that? I mean, I'm not going to live. That's the problem. That's how people see it. Before we leave that, it's also part of the culture. This is a new thing. In the past, that's not how people perceive the situation. Doctors and medical people cannot do much. You really die. They try to take care of you and try to do the best they can, but there's not a lot of things they can do. I mean, before the boom of modern medicine and medical science and technology, so it's all about caring. But right now, people see medicine and they see people who will solve your problem. You can be happy if you do the pleasurable things, you eat fast food and things like that, even if you know that it might be bad for you, but don't worry too much about it, because, if you do get sick, you go to the doctor, they will give you some medication and you go back to how you were living. That's the headache of preventive medicine and lifestyle medicine. That's the reason why we ended up seeing lifestyle medicine, preventive medicine, the primary care disciplines, because, there's huge gaps that needs to be filled up. That's also the reason for hospice and palliative care. Now, what about this home care thing? Well, the problem with any new young discipline, they develop and they come to a point they have to make a decision. And the decision is, we have to change the system. We have to influence the medical community. And how do we influence that if we're outsiders? So you have to enter the fray. You have to enter the confusion, because you cannot influence people it's harder to influence people from the outside. Do we go in? Meaning, do we tell them we want to be a specialty field? We want to be just like you, just like cardiologists, the family med people had that dilemma also. any field that became mainstream would have that kind of dilemma, geriatrics and hospice and palliative care. And there's two camps. The opposing group would say, there's a big chance we won't be able to change them. And there's a big chance they'll corrupt us. They'll change us instead of us changing them. Because first of all, we want to join them. It's not like they want to join us. So for them to accept you, you have to act a little bit like them. So there's a real risk that they'll change us instead of us changing them. And if they change us, then we might become part of the problem. We might be supporting the problem. We might not be addressing the problem. We just legitimized the problem or validated what they're doing right now, or just put a band-aid on the problem. So the other camp would say, no, it's not going to happen. We just have to keep our guard. But the only way to influence them, to tell them to start paying attention to quality of life and distress and suffering, is to be part of the community. They have to accept us. So you first act like them, and then you deliver the message. And just try your best not to get influenced or get corrupted. So that's the dilemma. Now, of course, we know what happened. We know that certain fields got mainstream, including hospice and palliative medicine, family medicine, preventive medicine, yes. Lifestyle medicine, not yet. Geriatrics, yes. And so, the story usually is, of course, it's so obvious. It's a huge community with a lot of financial motivations, and it's like a little tiny David. It's not even David and Goliath. It's like an ant against Goliath, or like a small dog against Goliath. It's not even a David. Right? How can you change that huge thing? It will take a miracle. So most of the time they got changed. And so that's what happened with hospital palliative care. We want to join you. And then the question is, well, you have to be scientific. So that's the first thing. Okay, we'll do research on the stuff we can do research on, just like what you're doing. So of course you can only pick and choose the stuff you can do research on, because it's a comprehensive holistic thing. Well, we can do pain, we can do terminal dyspnea, like people who are dying, try out different drugs and figure out what works well. We can do that. Okay, so that's fine. We can be somewhat scientific. And of course there's a problem with that. If you keep at it, then the drugs that we come up with, you can sell and you'll earn something from that. And the medical industry would like that. Now, of course, if you can keep on doing that, the industry, how the industry works, it motivates you. It pays for your conferences. You get to have researches, which costs a lot of money. You get published and things like that. You go on trips abroad to talk, or there's a lot of incentive to do just only that. You might end up focusing on those things and forget about the rest. Yeah, that's one of the concerns. Of course, the concern is valid, and that's the reason why hospice and palliative care doesn't look too comprehensive right now, overly focused on certain things, like, symptom management, and that's pretty much it. Because, the symptom management is the one that sells the products of the people who are paying for more than half of your enterprise, right? So there's another problem. They'll only accept you if once you're in, as long as you haven't changed them yet, they'll call you up, or they'll let you get in on the case if you're addressing the stuff that they need. So what do they need? Well, they don't need relief of suffering and improvement of quality of life. That's not how the other doctors think. Right? Nobody calls you up. It's a very rare referral when somebody calls you up and says, oh, I'm calling you up because I noticed that this person is suffering, and, we want you to address the suffering, or this person is poor quality of life, and we're calling you for that quality. Nobody does that, right? So, that's not the main motivation for the referral. The usual motivation would be getting the person out of their practice, or out of the hospital, or into home care, because they're running out of things to do. That's a big motivation, right? Or the motivation is, you cannot cure them, you just pass it to someone else. You don't need to care for them because there are other people who will care for them. Just stick with your cure approach. And then if you cannot cure anymore, then give it to the people who are supposed to care for them. Now, if that's the case and we went along with that and found it very lucrative for us and never changed for the next several decades, then we become part of the problem, right? And that's pretty much what's been happening in many places, even in developed countries. It became somewhat part of the problem. Never really changed the system. So why would you, of course the question is, why would you do that? I mean, why would you give the case to someone else? Why would you get the patient out of the hospital? I mean, you get paid more or you'll earn more if the patient is in the hospital, getting more gadgetry procedures and medications and things like that. And you won't get paid if you pass the patient to someone else. The detail is the patient's already dying and there's not a lot of things you can do that would benefit them. It's either that or they're running out of money or insurance not going to pay for the other expensive options that you have that might work. Meaning there's no financial motivation or financial return or income that's coming. So for doctors, the other things, you round on them. They're in the hospital because they're sicker, they're dying, and they ask you what else you can do. And in their mind, there's nothing you can do. You're in this cure, prolonged life approach, and so you feel guilty. There's nothing to say. On top of that, you're not ordering anything. And you'd rather take care of people you can cure. You'll be so grateful, and then you feel good about yourself when you get paid. This one is just going into the room, feeling like you cannot do anything at all. You can actually do something. And that was the original intention, to tell these specialists that they should start caring for their dying patients, even if they cannot cure them anymore. That was the original intention of Hospice and Palliative. That's the reason why there was a movement. Now the movement became something like, well, if you cannot cure them, then give it to someone else. We created a certain group of people, weird people, because, that's not that kind of thing everyone likes to do. And they're the ones who will care for your patient. So then it becomes part of the problem, right? That's also the reason why it's hard to get people into hospice and palliative care. That would work if there's a lot of people who will go into the field, and then you have a lot of manpower and personnel to take care of the caring part for the dying. The question is, who would want to do that? I mean, if I was a medical student, I'd rather become the specialist who cures a lot of people rather than the specialist or the nurse or the doctor or the provider who takes care of dying people, right? And who would want to do that? That's not a really good solution to the problem. The real solution is the original solution. You create a movement and you start telling everyone to do as much as they can to take care of their dying patients, especially since a lot of times their dying patients won't require very specialized, highly technical palliative care. They can actually do it. They just need a little bit of reorientation and a little bit of additional knowledge and skills, and that's it. And most of the medication and the procedures, they already know, because this patient's still dying of heart failure. And some of the stuff that you do to make them better are also the stuff that you do to make them more comfortable, even if you cannot make them better, even if you cannot cure them. Some of the stuff that you do to cure them and prolong their life are also the same stuff that you do to lessen their symptoms. The stuff that you do for your friend and your mom when she's feeling bad because they're sick is also the stuff that you do for your patients. And of course, you can get more knowledge base and skills so that it's going to be more structured. Sometimes you don't need a lot of structure. You just need to do it. Communicate well, support them emotionally, get the pastors involved or the priests involved, get counselors involved. I mean, these are not very difficult stuff. In reality, you only need the specialized palliative care team, the well-resourced team with the nurse and the counselor and the 4 or 5 extra personnel aside from the doctor. You only need them for the rare situation when there's a lot of complicated sources of suffering going on. Most of the time, you don't need them. And of course, most of the time, hospitals and countries don't have them. It's hard to support that team. That's the other concern we mentioned. How do you support that kind of team? Well, in today's environment, you cannot. Imagine if you have a 3-man team, that's a very small team, and you look at what they need to do, right? You need to salary 3 people or salary 2 people, and then the doctor has to earn his keep. So where's that money going to come from? The patient doesn't need a lot of x-rays or CT scans or MRIs or a lot of procedures. Sometimes it's just a simple infusion with some sedatives and morphine and simple medications. And you don't earn as much from that compared to the other kinds of patients. Definitely not enough to salary a lot of people in a good multi-professional team. How do you do that? And the answer is you cannot. In most less resourced communities, even in developed countries, I mean, you just get out of the affluent parts of that country and you see that, there's no way to support a multidisciplinary, multi-professional team. Now, in developing countries and poorer countries, obviously you cannot. It's a good idea, but it's not well resourced. So it cannot deliver what it's supposed to deliver. And that's the reason why it's not doing it. Okay? So that's the reason why you want it out of your way. I mean, you don't feel good if you cannot do anything if you're the doctor. In the hospital, you're thinking, if it was another patient there, I would earn more because that patient would need a lot of stuff from me instead of this dying patient. And sometimes this dying patient cannot pay anymore. It's illegal for me to send this patient home without his consent or without any plan when they go home. So maybe the hospice people can go in there, try to convince them to accept their fate, and maybe offer them something that's decent enough for them to accept so that they would agree to go home or make do with a shortened life because they won't be able to access the hospital anymore. And, convince them with whatever they say, like you might be suffering more if hospice would say all sorts of things, right? The idea is we hope that they would do that so that they don't just stay in this room and keep on piling debt that they cannot pay anymore, so which the insurance cannot pay anymore. And that legitimizes it. The problem is if the hospice people and palliative care people convince them to go along with it, they might not even be able to deliver what they promised because it's a poorly resourced service in most places. Also, it's hard to convince someone if you're the doctor trying to convince them to, pick home care and be more conservative with the approach. If you yourself know that you can live a lot longer if you have access to the emergency room, if you have access to the stuff in the hospital. Now, in some places where insurance covers hospice, you sign a piece of paper limiting your access to the hospital. So who would want to do that? Right? So if you're the doctor and you say, well, if I was that person, I'd rather not go into hospice, and you're having second thoughts yourself. How can you convince this person to go into hospice? Right?